Good morning. Today's topic is on evidence-based dentistry. Learning outcomes. At the end of the lecture, the student should be able to describe the hierarchy of evidence-based dentistry, list the steps in determining evidence-based approach in managing oral health issues. Introduction. In our day-to-day life, as a consumer, we take many decisions. Not all these decisions we take are based on information from consumer reports, authorized publications, and experimental results. Even dentistry is no exception to this, either in usage of dental materials, treatment modalities, teaching and research, etc. Each day, consciously or unconsciously, we make decisions regarding our patients' care to make clinical decisions almost instinctively. We draw on a wealth of resources, including our own clinical experiences and discussions with colleagues. We rely on textbooks, journal articles, seminars, continuing dental education program, and previous education. Good and sound dental practice relies not upon bits and pieces of selected evidence, but rather upon the collection of best available research evidence. Evidence-based approach is ideal in today's situation, and it is important that these clinical decisions making incorporate the best available scientific evidence in order to maximize the potential for successful patient care outcome. So, evidence-based dentistry, abbreviated as EBD, is an approach to oral health care that requires the judicious integration of systematic assessment of clinical relevant scientific evidence relating to the patient's oral and medical condition, that is history, with the dentist clinical expertise and patient's treatment needs and preferences. So evidence-based dentistry depends on three factors, namely the first is the evidence, the second is patient treatment needs, then clinical expertise. So all together will lead to an evidence-based decision. Coming to the history of evidence-based dentistry, the establishment of journal on evidence-based dentistry first appeared as a supplement in British Dental Journal in 1998, and later it became a standalone journal in 2000. In the year 2001, the Journal of Evidence-Based Dental Practice was first established in United States. The DSM Fawcett Center for Evidence-Based Dental Research was established in Boston in 2003. Coming to the goals of evidence-based dentistry, evidence-based dentistry has two main goals. The first is best evidence or research. Second is the transfer of this in practical use. This involves four basic phases. The first is asking evidence-based question. That is framing an answerable question from a clinical problem. That we will explain in the further slides. Searching for the best evidence. Reviewing and critically appraising the evidence. Applying this information in a way to help the clinical practice. Kerr and McGivney have suggested an additional phase, that is the evaluation of performance of the technique, procedure, or materials. Stages in process of evidence-based dentistry. The evidence-based dental process is based on the abilities and skills of the clinician, This process includes the following steps. The first and foremost is identify the clinical problem. Then go for searching of evidence. After searching, make a sense of evidence. If it is not good standard, then discard. If it is good, then you try to update that evidence. After updating, act on the evidence. If I give you example, then you will understand how these steps in the process of evidence will go. The first step is identify clinical problem, converting information into a question. How you can do this? The first step in evidence-based dentistry is asking a clear question about a clinical problem. The question must be relevant to the patient's problem and phrased in such a way that it will point you towards relevant and accurate answers. Questions are often related to therapy, diagnosis, prognosis, and causation. Most often, the original question is too broad, so narrowing it down involves using PICO format. So, in identifying the clinical problem, we are using PICO. The basics of well-built question includes the patient problem, that is P stands for patient problem. Starting with your patient asks, how would I describe a group of patients similar to mine, or be precise yet too brief? The second is intervention, that is treatment task, cause, prognostic factor. Ask which main intervention I am considering and be specific. The third is, that is C stands for comparison. Asks what is the main alternative to compare the intervention and be specific. Then the fourth is O, that is outcome. Ask what can I hope to accomplish, that is outcome. So if I give an example, like for the PICO, the first P, patients with osseointegrated implant. So which implant? Then the intervention is who smoke, whether we can give this implant to the smokers. C is compared to the patient who do not smoke. Then what is the proportion of implants survived after the end of 10 years? That is the outcome. One more example. For example, patient comes with you with anterior tooth which is broken due to trauma. Assume that fracture is class 2, that is dentin is exposed. So the patient with trauma, anterior teeth. So intervention, you may go for GSE or you may go for composite. So compare composite and GSE. Outcome, which one will give best result? After searching the evidence, after discussing with your colleagues and reading some articles, you will come to know that composite is good. So that is the outcome. So survival rate of composite is good and aesthetically it is good. So you are going for composite. That is the outcome. Like that you have to decide a treatment or a diagnosis based on evidence-based approach. Coming to like how you will search for evidence. After establishing a question, the next stage is to search for evidence. Evidence can be derived from the number of sources. Richard and Lawrence in 1995 suggested that there are 4 basic routes to finding the evidence. The first is ask the expert. Then read the textbook, find the relevant article, search a database such as Medline or Cochrane. The first is ask an expert. Asking a consultant or a colleague is an efficient way of getting an answer to a problem. But drawback of this approach is they may not be completely aware of all the up-to-date evidence. Often hold a quite subjective opinions about the particular issue. For example, if you ask me, I have not updated with the clinical things from past 3 years because I'm not working as a clinician. So if you ask me also, I may tell you some biased answers. And always, I won't prefer orthodontic treatment because it will definitely relapse after 3 months, 3 years. So it's my subjective opinion. I'm just giving an example. So I'm not the best person to ask. You should ask several people who are expertise in the specific field. Later, you have to take your own decision after consulting all of them. You are also having other options, a reading article and your colleagues, so that you can take all the opinions and reviews of whatever treatment modalities you have to be taken in future. Then read the textbook. It's a good idea, but there is evidence that they rapidly go out of date even when new. See, previously there was a situation to get your knowledge doubled, you will need almost like 5 years. Now, in 30 minutes, your knowledge will be doubled. If you are searching on particular thing in database or internet, your knowledge will be doubled in 30 minutes. So, even the textbooks will rapidly go out of date even when new. Find the relevant article, but you may not have relevant reprint, and even if you do, you never get around to reading it properly. So then you may ask me, then what we have to do to get the proper evidence? You have to follow all the 4 steps. Search a database such as Medline or Cochrane. It would appear to be the best way to gather the evidence, as it will be the most up-to-date and quite comprehensive. Access to the literature via the internet is simple procedure, but there is a danger of becoming swamped with articles that are not necessarily relevant or scientifically sound. For example, if you put in internet like difference between composite and GIC, you will get many articles. In the meantime, you will be not knowing which article you have to select and read. That is the problem with database. So you should know which journal is good, which journal will publish high quality articles. That you should know. Then you have to go for that journal and you have to search for the evidence. The 12 tools for assessing evidence. The first is be skeptical, that is always doubtful. Don't agree with anything. Then don't trust biological plausibilities, that is apparent validity. You should have clear-cut validity. What level of controlled evidence is available? Control means they should have compared with different materials of similar treatment. Then if you found one is good, then you have to keep it for practice. Then did the cause precede the effect? You have to check this. No betting on the horse after the race is over. It's like buying a ticket after the train went. Then what is clinically relevant pre-trial hypothesis? That is your null hypothesis. And population size means whether they have used correct population or number of samples, that you have to check while you read your articles. Is there even one different explanation that works as well or better? For example, I have told sometimes authors' individual perceptions, their subjective perception will be there, so they may give different explanation. But you have to search and you have to take the correct decision. Was the study properly randomized? Always randomized studies are good because they are giving equal chance to everyone, and they have set of procedures, standardized procedures they have to follow. So always go for randomized trial for the clinicals. When to rely on non-randomized evidence? Sometimes you can't do randomization all the research. So sometimes you have to go for non-randomization. So such kind of things you have to know, like where you go for non-randomized, how will be the result, how should you accept that result. If in case if you are having doubts, how to resolve that results which are obtained from non-randomized evidence, that things you have to think. Then placebo effect. I hope you know what is placebo. Placebo is like, for example, if you are giving, for example, there are two groups and you are going to do a research on hypertension. Your null hypothesis is whatever drug you are giving to the patient will reduce the systolic blood pressure. Alternate is it won't reduce the systemic blood pressure. There are two groups are there. For one group, you are going to give the drug whatever you invented. The second is it looks like a drug, but it's not a drug. It's just a mint or something like that. But to get no bias result or zero bias result, you have to give the patients with such kind of things that are called placebos. Actually, it don't have any efficacy or efficiency, but it will resemble the same as the drug, whatever you want to give in the clinical trial group, not for the control. Then, was there protection against the conflict of interest? Conflict of interest will be within the authors. So, hierarchy of the evidence is as follows. In the lower one, there will be in vitro research. That means the research outside the body. Then comes the animal research. Then comes your editorials, opinion, ideas. Then case reports. Then case control study, cohort study, randomized control study, then meta-analysis and systematic review. If I ask you which one is the best evidence, then you have to go for systematic review. But cohort study is also good because cohort study will take minimum 2 years to take decision. So above this all are good, but systematic review will be in the top. After that, randomized control trial. So making sense of evidence. Once you have gathered your material, the next stage is to appraise it and see if it is makes a contribution to good evidence about your problem. After you have appraised the material, you decide to discard it or keep it. Critical appraising the evidence. The evidence has to be critically appraised for its validity, impact, and applicability. This involves ensuring that the sources of potential bias have been eliminated and appropriate statistical methods have been used. The outcomes are appropriately summarized so that the decision can be made based on their clinical importance. Applying evidence-based dentistry to patients. One of the ways that validity of information is assessed is the extent to which it can be applied to patient's care. However, certain specific points must be considered while applying certain types of information to patient care. These are considered below, like diagnostic test. Practitioners must be assured that the tests are available and it is accurate, it can be affordable and precise in their setting. Clearly, the patient must be willing participant in diagnostic procedure with the exception of obtaining valuable new information that will influence the outcome of justify the additional cost or discomfort. This is for diagnostic test. Then the prognosis. Whether the information in the article about the prognosis of the condition should be applied by answering questions like adverse effect of the drug, success rate, etc. Then therapy. Certain questions specific to articles about therapy will help determine when to apply improvements to patient and when not. Then evaluating the outcomes. This is the final step in the process of evidence-based dentistry. This is to evaluate the effectiveness of intervention and clinical outcomes and to determine how effectively the evidence-based decision-making process was applied. So coming to the advantages of evidence-based dentistry, to know the best evidence research, you will have dentist, patient, then researcher. So advantages for the dentist: high quality care can be given to the patients, with a greater confidence, good rapport with the patient. Once the patient get confidence in you, then patient will have good rapport for you. Then satisfaction of offering the best treatment, effective use of resources, monitor and develop clinical performance. So these are the advantages for the dentist. Then for the patient, needs and preferences are valued because you have given what the patient want. The desire of the patient is fulfilled by your treatment. Then improve treatment. Definitely, if you are practicing evidence-based practice, then your treatment level will be improved. Then satisfaction of receiving the best care to the patient. No need for second opinion because you know whatever treatment you have given is good and it's very optimist. Less chances of harm and saves time for the patient, for you too. For the researchers, keep the profession alive by testing new products, new techniques, and test before clinically applied are used. Then can apply research to community needs. These are the advantages of evidence-based dentistry. Tradition-based dental care versus the evidence-based dental care. Previously, how we were following, and present, how we are following. Traditional-based dental care and evidence-based dental care offer complementary paradigm for clinical decision-making. Tradition-based care emphasizes the primacy of knowledge, experience, and intuition in the exercise of good clinical judgment. Evidence-based care emphasizes the integration of good judgment with the best available evidence and patients' values in making of clinical decisions. Paradigm shift in the healthcare, that is from the traditional practice to evidence-based practice. Unknown basis for the evidence in the traditional practice, but in the evidence, it's the best evidence. You are using the best evidence in the evidence-based practice. In the traditional practice, limited or incomplete appraisal of quality of the evidence. But in the evidence-based practice, you have systematic appraisal of quality of evidence. In the traditional practice, subjective, opaque, potentially biased results you are observing. But in the evidence-based practice, it's objective, transparent, and less biased. In the traditional practice, black and white conclusion, that means you don't have exact proper conclusion. In evidence-based dentistry, you are getting acceptance of levels of uncertainty. You will have the accurate results. In the traditional practice, age of expertise, then in the evidence-based practice, age of science. The problem are barriers to introduce an evidence-based dentistry. Richard and Lawrence in 1998 note 4 problems of introducing evidence-based dentistry. The first and foremost is amount of evidence. I already told you, if you go and put something in Google to search, you will get n number of results. That time you should know which one you have to consider. Then the quality of evidence, then dissemination of evidence, then practice based on authority rather than evidence. Amount of evidence. Currently, over 2 million biomedical articles are published annually in some 20,000 journals. You just imagine, we won't read one article in one journal. For example, a journal constitutes about 20 articles. So to read one article, if it is taking 10 minutes, then 20 articles, it will take how many hours? So and assume 20,000 journals. So you have n number of things. You should be selective in selecting the articles. There are about 500 journals related to dentistry. Clearly, not all these articles are relevant to all areas of dental practice, nor can one hope to read any more than small minority. Quality of evidence. A number of publications that are widely read in dentistry are not subject to peer review, and even when they are there is the tendency for publication bias. This bias may not be explicit, but there is a tendency both by the researchers and editors to publish positive reviews. Negative trials can be equally valuable, and concerns have been raised that increasing sponsorship of medical trials by commercial concern could result in non-publication of negative findings. So here you have to check for negative trials also, where they went wrong, what was the wrong, whether they have done in the research design only wrong or the sample selection is wrong. So that you can identify by reading the negative trials. But the problem is none of the articles will report the negative trials. Dissemination of evidence. Unless good methods of dissemination are available, even where there is a good evidence, it can take many years for particular treatment to become the norm. Practice based on authority rather than evidence. For example, the use of techniques or therapies based on the views of authority rather than evidence may lead to wrong treatment being performed. That means somebody is insisting you to do that treatment, even though you know, or the person who is insisting will be knowing that treatment is not an evidence-based, but still they are insisting you to do. So that things we have to avoid. The impact of evidence-based dentistry on the dental research community. The EBD opens a new era in dental research. This movement can bring together a traditional basic science researchers with clinical researchers, clinicians, and educators. The current barriers that exist between the dental research community and the practicing community can diminish as evidence-based teams start to work on finding, appraising, summarizing, and analyzing the evidence to answer clinically relevant questions. Dental research results are raw. Evidence-based dentistry represent a potential strengthening of the complex process of science transfer of translating research into practice. Failure or success of evidence-based dentistry will affect dental researchers' implied contract to improve the oral health of the public. To conclude, the concept of evidence-based dentistry with a view to keep abreast with the evidences in dentistry, the importance of evidence for every branch of dentistry in teaching in order to orient the practitioners among the great amount of most actual scientific informations and to support clinical decisions is well established in dentistry. The practice of evidence-based dentistry is a process of lifelong, self-directed, problem-based learning which leads to the need for clinically important information about the diagnosis, prognosis, therapy, and other clinical and healthcare issues. All healthcare professionals need to understand the principles of evidence-based dentistry and practice, recognize the evidence-based practice in action, implement evidence-based policies, and have a critical attitude to their own practice and to evidence. Without these skills, professionals and organizations will find it difficult to provide best practice. Evidence-based dentistry is a way of thinking, philosophy, a paradigm, and it is practice of dentistry for the millennium.